Hello and welcome to Two Peds in a Pod, the medical education podcast from the Children's Emergency Department at Derby. I'm Ian Lewins, your host today, one of the consultants in CED, and I'm very pleased to be joined by Dr Nigel Ruggins.
Hello.
Good afternoon, Nigel.
Hi.
And you're a general paediatrician with a respiratory interest.
That's right, yeah.
So today we're going to talk a bit about Wheeze, which is an incredibly common presentation to GPs, to ourselves. And when I was thinking about this, I thought, actually, at some point, I'm sure all my kids have wheezed.
Yeah.
Why do kids wheeze then?
Well, it's a very common reaction to viral infections and to other stimuluses. What we do know is that asthma as a cause of wheeze is prevalent in about 1 in 11 of children, and that can appear at any age. But if you look at the preschool child that wheezes, then around a third of children that are preschool will wheeze at some stage in their life. So it's incredibly common.
And I think it's sort of the second commonest presentation to GPs that after fever is wheeze. And I think most people feel comfortable in diagnosing something like bronchiolitis.
Yep.
So you've got a baby in winter, hopefully. Well, I've seen my first this week.
Yeah,
deeply worried.
starting to come.
Not feeding, wet cough, wheeze, crackles. I think people are comfortable with that. The question that's sort of often put is, how about when they get... And we don't do anything for the bronchs.
No.
But once they sort of get to 13 months, 14 months, 15 months, when do we start to think... Where does the overlap between sort of viral-induced wheeze and bronchiolitis, and does it matter?
Yeah, well, you're absolutely right in that when you see a classical bronchiolitis in a young baby, it's very easy to recognise and diagnose, and we know that any attempts at any therapeutic treatment in that group makes no difference at all, either in the short or long-term outcome. Whereas there is this overlap period where young infants do get wheezing associated with viruses. And of course, one of those viruses may be RSV, which is the bronchiolitis virus.
Yep.
So it is a clinical diagnosis, and I would say we don't need to get very hung up about it, because it's only really around that age of 12 to 18 months that you would see any response to bronchodilator treatment, for instance. So no one would get worked up about somebody trying a bronchodilator in that age group, but just to see whether they can show any short-term response. And if they do, then it's probably appropriate to continue with it. But if they don't, then it's certainly not worth upsetting the child and carrying on.
And that's a key thing, isn't it? It's if you've done something, you've got to go back. And has it made a difference?
Absolutely.
It's not just a do it and walk off.
No, and that's true with Atrovent, ipratropium bromide. We know that there have been some studies that suggest that younger children may respond to that. It works in a different way to the standard beta-2 agonist. So again, it may be worth a try, recognising that you don't get the immediate response that you do with beta-2 agonists. It may take 10, 15 minutes, but actually seeing whether there is a response or not.
Yeah, and that's important.
Yeah.
And so we sort of say move on, and then there's this other sort of misconception, or I don't know whether it's a misconception or not, but this idea of you've got to be a certain age to have a diagnosis of asthma. You're too young to be diagnosed with asthma. Is that complete nonsense?
That is complete nonsense.
Good.
We know that asthma can present at any age. It is true that the older that you are, and again in episodic wheezing or chronic respiratory symptoms, the more likely it is to be asthma. And as I say, when you get a single presentation in the emergency department of a child with wheeze at under a year, it's probably not going to be asthma, but there are things that might indicate that this child is going to be at risk, and this may be the start of an asthmatic disease.
Yeah. So I guess you get asked to see a lot of kids in your clinic with, could this be asthma?
Yeah.
What's your sort of approach to what sort of things would you ask in the history from the parents and from the child if they're old enough?
So first of all, analysis of the symptoms, because I think that's where we all start. And asthma is fairly straightforward in that there are 4 things that you need to know about: cough and the nature of the cough, wheezing, breathlessness, and chest tightness, which of course you can't really assess in a smaller child. So it's trying to evaluate those various symptoms. Each symptom on its own is a very poor diagnostic prognosticator, but as a combination, it may well support the diagnosis of asthma. And then you need to look at other supporting evidence. So is there a history of other atopic disease in this child? Is he eczematous? Has he got food allergy? And then looking at the family history and first-degree relatives. So has he got brothers and sisters with well-defined asthma or parents that have got it? So those are all risk factors that tip the balance towards the underlying cause of their wheeze being asthma rather than one of the more common episodic viral wheezing type problems.
And I guess that's really important for parents sort of longer term. I guess from our perspective in the emergency department, whether it's asthma, whether it's viral-induced wheeze, the immediate treatment doesn't matter.
It doesn't, no. So the immediate treatment's the same, but in terms of longer-term treatment or longer-term implications for that child and the parents, then it really does matter. But we should never be in a rush to make a diagnosis of asthma. And I think now when you look at the latest BTS sign guidelines and the NICE guidelines, it's very clear that it should be a continuing evaluation process. And so, yes, some children you'll get to that diagnosis very quickly, some it will evolve over time, some will come to you with a diagnosis of asthma and you'll end up actually unravelling it and saying, well, actually, this isn't asthma.
I think that's a really important point, is that it's a continuous evaluation, as you said. It's because I guess some people would come to you wanting a label.
Yeah.
Maybe that's the wrong word, but wanting a diagnosis and actually having to say, well, it could be, but we need to sort of see.
Absolutely. And, I think that's our experience over time in clinic, that the diagnosis will sometimes evolve or actually be unresolved, or will completely clear up and there won't be any long-term issues. So, and again, the severity of symptoms don't really seem to play a part. So you and I will know a number of children who've been in and out, maybe even needed PICU support, but HDU support for their treatment of wheeze because it's so severe. But actually, when you follow those up, if they've not got the chronic symptoms in between, they've not got the strong family history, you may look for atopic features with them, you may do other things to exclude other respiratory problems. And if you find none of that, even though they've been so bad as youngsters and toddlers, they actually outgrow that problem.
And is spirometry something that you would sort of routinely do in clinic? And what sort of age of kids?
So we're much more used to doing it now. In fact, we wouldn't be without it. So sometimes I'll be doing spirometry and taking a history and talking to parents, and then I'll realise I've forgotten to listen to the chest. But it is a very, very useful tool. So children of around 5 and above may be able to do it. We do have some younger ones. We do have some 12-year-olds that don't get the technique. So it is about their ability to do it. But looking at spirometry is really important to see if there's any evidence of airways obstruction. And if there is that airways obstruction reversible with a bronchodilator? And again, the other thing is that we also recognise that asthma is an episodic illness. So it's not about just doing that when they're well, because when they come to you in clinic, they may actually be absolutely well, but actually demonstrating the fact that when they're not so well, when they've got chest symptoms, they've got that variability, they've got that abnormality in their spirometry. So it may not be there all the time. So again, going back to my point that you may not be in a rush to make a diagnosis of asthma. You need sometimes to see them when they are symptomatic or assess them at those times.
Yeah. And how about things like sort of plain radiographs? Do you use them a lot in clinic?
I tend to only use them for those younger children where they're under 2, because occasionally you will find structural abnormalities that you'd never pick up otherwise, or if there are atypical features, or perhaps they're failing to respond to what you think is an appropriate intervention. Certainly, we don't keep doing X-rays, and I have been caught out once or twice by very young wheezers where I thought, oh, this is just a viral episodic wheeze, who subsequently come back and had an X-ray, and we've actually found something, that's relevant.
Because we kind of, at some stage, I think we got into this mindset of first presentation of wheeze to the emergency department, get a chest X-ray. And I'm not sure why, and I think we've kind of moved away from that.
I think we have moved away, and again, once you've got a diagnosis of asthma, there's certainly no real indication to keep doing X-rays, even if you're, severely symptomatic at the time. So I think that has moved on, and when we've audited our use of X-rays, it's definitely much less. Again, they have a limited value. I have a low threshold in the very young chesty wheezers, a much higher threshold in older children.
Okay. How about the happy wheezers? Are they a completely sort of different group? Or are they part of a spectrum, do you think?
I think they are part of a spectrum. There's no doubt that you see these slightly overweight, chubby babies who seem, very happy and tolerant of any symptoms. And again, if those are followed up, they're the ones who will tend to not have long-term problems. They tend to be resistant to any of the treatments that we use. And again, it's about reassuring the parents that there aren't any long-term consequences, and that their child is thriving, if not over-thriving. Yes. So it's recognising that still as a group.
Yeah, because some of these, they sound awful.
They do.
And you think, I must give them something, and nothing makes a difference.
And again, that's often why they end up seeing you in clinic, because people comment to the parents when they're out shopping and say, oh, have you not seen your doctor about your child's chest, and it's horrible? And a lot of those babies also, a lot of their extra noises are upper airway noises. So these rattlers that clearly are quite noisy and symptomatic. And again, there's no evidence that they cause any long-term problems at all, and that's often what the parents are worried about.
So thinking about the wheezes that we're going to see, there's the asthmatics, there's the bronchiolitics, there's the viral-induced wheezers. Are there any other things that we should be looking out for? I mean, the things in my head are, could this be cystic fibrosis? Are those the other things? What other things can present as wheezes?
So obviously there are sort of atypical infections, the things like mycoplasma, those sorts of things that we always think about if it's a first-off episode and there's something not quite right with it. And my cystic fibrosis patients, I do have 2 or 3, so out of about 28, that do get intermittent wheezing, but it wasn't how they presented. I have had the experience of having one inverted commas severe asthmatic referred to me many years ago. And when she came to clinic, she was clubbed, and she clearly was not an asthmatic, and she did turn out to have cystic fibrosis. So all those other differentials just need to be in the back of your mind in case there's something atypical about it. So, the standard things on examination: is this child thriving?
Yep.
Is he clubbed? Is there anything else? Are there upper airway issues that may be contributing? So, in a small baby, has he got tracheal tug? Could this be a laryngotracheomalacia type problem or bronchomalacia type problem? So it's all those bits. The vast majority of the things are going to fit into those simple diagnostic boxes, but just keeping that eye open for those additional things that might just ring alarm bells.
That doesn't quite fit with
that common pattern. And of course, it can be very difficult when you're seeing, particularly in the middle of winter, wheezer after wheezer after wheezer, to identify one that just isn't quite right. And
certainly know with the neurologists, they use a lot of video images off phones. Do you sort of use that? Do people come and go, look at them, look at what they're doing, look at this noise, look at this cough?
And it can be very helpful. Recording cough, recording particularly breathing issues at night. Some parents say, oh, they're always coughing and they're very wheezy and heavy breathers at night, and they show you a video, and it's clear that they are working hard when they're asleep, and it's very clear that often it's an upper airway issue related to adenoids or tonsils rather than anything else. But again, that use of those tools is really helpful sometimes.
Because I think one thing I get across to my sort of medical students coming through is what you might mean by wheeze might not be what parents mean by wheeze, and often sort of making the noise and doing that expiratory noise.
Absolutely. I do a great impression of obstructive sleep apnea, which I have to put into my clinic not infrequently. But you're absolutely right, because the studies have shown that if you ask a parent about noisy breathing, they will always call it wheeze. The only exception really is if they're asthmatic themselves, or they have actually recognised wheeze. And so there was a study done years ago down in London at the Hackney Children's Hospital, and at that time what they did was, when they respiratory clinic was running on, they actually showed little videos to parents of different types of noisy breathing, and they found that actually helped them resolve what the breathing issue was with their child. The other thing, now, more modernly now, going back to the BTS sign and the NICE guidelines, they talk about now medically, professionally diagnosed wheeze. So they're actually asking for some documentation as to somebody who knows what wheeze is, having heard it. And it's interesting, because one of the things that I've often done is when they come to see me in clinic and they said, oh, we were up in CED and they said we were really wheezy and things, I'd always look at the discharge summary, and there'd always be something that said chest clear. So there are ways, and so that's been introduced in those guidelines to try and tighten up what we mean by wheeze.
And that's important, because I think sometimes when people come to see me and they say, oh, he's been told he's got asthma, it's not in a challenging way, but I say, well, who's told you that? And why have they told you that?
Yeah.
That's quite a reasonable thing to do, isn't it?
It is a very reasonable thing to do. And, when children come with a label of asthma and on all sorts of treatment, it's actually quite difficult. It's quite hard work to get them off of that and to undiagnose them. Again, it's not something you can do in a hurry. You've got to get the parents on board with it, and it will, take some time to do it. But the value is that child comes off of treatment that he doesn't need, that are not improving his symptoms. He gets that diagnosis gone, and the cost to the NHS of treating children with inhalers that don't need them, is not insignificant.
Yeah, and we'll talk about inhalers in a next podcast. But I guess one of the key things for us in ED that I'm sure you'd want emphasised again and again is plans. Yeah, a written plan. We must be doing written plans for these kids. We
must. So this really comes from the NRAD study looking at asthma deaths. It was published in 2014. And unfortunately, there were a good number of children asthmatic deaths in that. We're still not doing very well with it, but it was highlighted that a very, very small proportion of those children actually had a written down asthma plan. And I don't think it's the plan itself that's important. It's the fact that somebody's actually gone through a plan with their parents, whether it's written or not. But that's what we're being audited on, whether we do write it down. And what we tell parents also is a useful thing to do is to actually take a photograph of that plan on their mobile phone, because they probably won't have the plan with them, but they almost certainly will have their mobile phone. So they'll have somewhere where they can refer to it.
And it's simple things like checking technique.
Absolutely.
And, say, what would you do if and when would you seek advice?
Absolutely. And so the plans have got much more simple. So in the past, they were very much around peak flows and that sort of thing. We've tried to get rid of that altogether and just to simplify it. So there is a national asthma campaign plan, which is very good, but we've actually developed one within the East Midlands strategic clinical network, which has been devised across Leicestershire, Nottinghamshire, Derbyshire, with the input of paediatric nurse and things, just to make it very straightforward and simple.
That's important, because the simpler the plan, the more likely people are to follow it.
Absolutely.
Let's be clear. Okay.
Absolutely.
So I think that's my take home, that we must, from an ED perspective, a plan. But you're quite happy for me to diagnose asthma?
Yeah.
Excellent, good. All right.
Good.
And not to diagnose asthma as well.
Yeah,
just as
that'd be good.
important. Undiagnose it. Perfect. Lovely. Thank you very much for your time, Nigel.
No
Cheers.
problem.